The pieces needed include a meconium aspirator hooked to a high-flow oxygen source, a 3.5 or 3.0 ET tube adapter, and then the needle and syringe. It's important to take the little filter piece off of the syringe, or off the needle rather, so you can connect the syringe so that it'll be ready to use. This is a demonstration of a needle cricothyrotomy intervention. First, I'm going to assemble my equipment and make sure I have everything. What I need is an oxygen tank capable of providing high flow, high pressure oxygen. That means I need a high flow regulator and tubing, obviously. I need to have a delivery device. In this case, I'm going to demonstrate the use of a meconium aspirator, which can be hooked to my oxygen tubing. We're also going to connect that to an ET tube adapter. We are using a 3.0 or 3.5 ET tube adapter because it will fit in line with this device, and the other end is the inside diameter of an IV catheter, so it will fit with whichever size catheter we choose to use. I also need to have my appropriate disinfectant available, and I need to have a large bore catheter, preferably a 10 to 14 gauge catheter, and I'm going to connect my catheter to a syringe to allow me to aspirate for air to ensure appropriate placement. Once I have my equipment assembled, I'm going to prepare my patient. Ideally, my patient is going to be in a hyperextended position and the patient's going to be adequately oxygenated or ventilated, but that's probably difficult to accomplish if we're in a situation where we've chosen to use this intervention. So once I've decided to do the procedure, I'm going to locate my landmarks, I'm going to find the cricothyroid membrane, and I'm going to prep the area thoroughly, disinfect it, and then I'm going to stabilize that area while I get my needle ready for the insertion. I'm going to insert in the center of the cricothyroid membrane. I'm going to push until I feel a pop through the membrane, and then I'm going to stop. I'm going to aspirate and ensure that I get a clear return of air, meaning that I'm in the trachea. Keep my needle anchored, and I'm going to advance the catheter to the hub. At that point, I can remove the needle, safely dispose of it in a Sharps container, and I'm ready to ventilate my patient. Again, with this device, I'm going to connect it in line as I demonstrated, and now I'm going to ventilate by covering the port for 1 second of inhalation and releasing the port for 2 full seconds of passive exhalation. Again, 1 second of inhalation and 2 seconds of exhalation. As I'm doing this, or have an assistant do this, I'm going to evaluate the effectiveness. I'm going to look for chest rise. I'm going to auscultate the lungs on both sides and evaluate the presence of breath sounds. And I'm going to watch for any other signs and symptoms. I can assess pulse oximetry. I can hook an end-tidal CO detector in line with this in order to evaluate both of those. And I also need to watch for subcutaneous emphysema or any other sign of complication. The other alternative way of ventilating in this case is to not use a meconium aspirator and a high flow oxygen, but rather a BVM attached to 15 liters as we normally would for ventilations. I'm still going to use my 3.5 ED adapter, put it in place, and I'm going to connect it to the catheter, and then by doing that, I can ventilate my patient effectively. Well, I can ventilate my patient. How effectively is a question. So as you can note, it is difficult to push very much air through a 12 or 14 gauge catheter. Again, we need to do 1 second of inhalation and 2 full seconds to allow for exhalation. We also need to secure this device in a way that isn't going to allow it to bend or kink the catheter in order to make sure it's going to keep working. Now, I encourage you in your practice to test out this theory. You notice how small that catheter is. You can ventilate through this. You can attempt to allow both inhalation and passive release, and you'll notice that it takes a lot of effort and there's very little air movement. So imagine trying to ventilate a patient entirely through that volume or through that size opening. It's a good reminder that we need to choose carefully what airway interventions we use and recognize that this may be a good short-term solution in an emergent situation, but it's definitely not ideal.